So good morning once again, and we want to officially begin the session. And on behalf of the entire NASCOP and our partner, the CDC through Palladium, I wish to introduce a team of facilitators who are going to take us through this session. And it's going to be individual introductions. So I will begin from my right hand. Just say your name and the organization for which you work, and then we'll get to the next level. I hope all of you can hear me. Can you hear me? If you can hear me, let's see by show of hands. You can?
Good.
Okay, good. So we proceed with the session. We have a brief introduction, and then we dive straight into the presentation. So from my right.
Good morning, everyone. I'm Diana Top. I work with Palladium.
Good morning, everyone. My name is Patrick Eshoke from Palladium.
Ngari Faith from NASCOP.
Milka Cheporil from NASCOP. Kalma Wako from NASCOP.
Omathega Kamau from Palladium.
Joseph Junge, Palladium.
Wanda Gitonga, Palladium.
Jacob Odiambo, Palladium.
Oscar Mwale from Palladium.
Stephen Osei, Palladium.
Colin Setemesi, NASCOP.
So thank you very much, Tim. We're going to get into the presentation, and probably before that, I will request Dr. Jacob to do the brief of the agenda that we're going to be going through, and then after that, we will begin the session. Thank you.
Okay. So thank you very much, Faith, and hello, everyone. We are going to go through a 1 hour and around 45 minutes of the presentation. You will have a number of presenters taking the stage to talk to you about the solutions that we are going to have. So welcome, and thank you for joining in. So, as we are beginning, I'd like to once again welcome you to this February Kenya HMIS 2 release webinar that we'll be taking you through. So first of all, I would like to just do a brief introduction. This webinar has been prepared in collaboration with the USG, the US government, the Ministry of Health, Palladium, and ITEC and other stakeholders who have supported us to enhance the health information systems over time. Note that during this webinar, we will be taking questions in the chat box on the right-hand side of your screen. We have someone who will be monitoring the questions, and they'll be answered during the course of this webinar and at the end of the webinar. So this is just a brief about the session objectives. I just want to confirm if people can see the session. Okay, if you can see the session, then we are good to go. So the objectives of this session. So we would like the participants to be aware about the versions of HIS that are being released today, and to know where to find the installers for the same. We would like the participant to be able to recognize the new features adapted to HIS, to the health information systems, and be familiar with some of these new features. We would like participants to know the requirements for system deployment at a high level, and also to be able to access training materials, and even more important, to be able to know how to access the help desk for the health information systems. So that briefly is a summary of the objectives for this session. Before we start, before we proceed further, before we proceed further, I just want to give you an overview of the session. So we have 4 main sessions during this webinar. The first 2 sessions will be dealing with facility-based systems. So session 1 will be Kenya EMR and Acute Care. Session 2 for the mobile applications that are currently in use for HIV testing services. Session 3 will be on the data warehousing solutions, and then we'll talk about training and support for the users. Then we'll have a brief session when we'll be responding to the questions, and when the USG and MOH teams will give us brief summary of the next steps. Next. So during this webinar, we have participants from different organizations. We have representatives from the National Ministry of Health, led by Faith Ngari. We have a team from the USG, Health Information Systems, HIS partners, service delivery partners, and representatives from the County AIDS and STI Control Coordinators team, and some of the other people are may have been invited through the link that we shared around. So a bit of the ground rules for this session. We would like you to take note of these rules because they'll help us to manage the sessions. The admin will, from our end, will keep all your microphones muted most of the time to make sure that we don't have a lot of interruption in the sessions. Questions will be received through the chat function that I've highlighted in the previous session. The Q&A session will be based purely on this chat session, unless maybe during the webinar we agree on a different approach. Then we would like you to maintain professional etiquette during the Q&A session so that we just maintain that along the presentation professional. Next. So the next thing that I would want to just highlight is a disclaimer. This is not a detailed product overview. It is just a highlight of some of the new features of the product and some key features that we may find is relevant for this session. Next. So I'll go straight into this session. So this is just a bird's eye view of the products that we'll be discussing today. I just want you to orient you on the diagram that is on the screen. So the solutions that we developed is used in two main levels. At the facility level, which is represented by the box that is bordered by a red color, and at the bottom of the screen. Then at the national level, we have solutions that are also implemented and represented by the box that is having a red boundary at the top. So at the bottom, at the facility level, in the box labeled Facility 1, we have applications that support clinical care of patients. That is basically the electronic medical records, the HDS applications, and the interoperability layer. And these have modules and the function that they support at the facility level. So you can see most of the boxes there are in green. So we have the HTS applications, an HTS module in the EMR, HIV treatment module that most of you are familiar with. Then we are on course to develop HIV prevention modules in the coming few months, together with the support for TB HIV activities. We have linkage to other health information products in the facilities, which includes the ART dispensing tools and other solutions that are being implemented in some of the facilities. So one of the other features that these solutions support at facility level is strategic information. So you're able to do line lists and reports from the systems in support of surveillance and monitoring of the program. At the national level, we have solutions to which we send data from the EMRs. A key feature that you'll be seeing during this presentation is electronic reporting to DHIS, which is a new feature that you'll be able to see. We have the National Data Warehouse, and then we also support case-based surveillance and smart card storage of patient records at national repositories. All these systems are connected through our interoperability layer and also our data warehouse API, which is called DYP Tool. At the national level, we are mainly supporting two areas: strategic information, unique person identification, and case-based surveillance. So you'll be seeing some of these things playing out during the presentation that we are going to have. We'll go straight into the sessions. So the first session will be on the electronic medical record systems. And I'm going to invite my colleague, Diana To, who will take us through this session. Diana has been very instrumental in technical supporting of the EMRs in the field, and now takes care of capacity building activities right now at Palladium. Thank you.
So good morning, everyone. Like you've heard, my name is Diana. I'll take you through KeHMIS and maybe just a brief for the people who've not interacted with the systems. So KeHMIS is one of the distributions of OpenMRS. So that supports patient management and it's in line with the standard EMR standards and guidelines. So KeHMIS supports currently HTS modules. It supports care and treatment, PMTCT, that's the whole MCH. And it's modular, so you can add different modules to support other programs that are not currently supported. So, this system benefits mainly from the international OpenMRS community that really contributes to its code and also the code and also the design. So I'm going through the changes that has happened in this KeHMIS. So I'll just go straight to the changes that have happened in this system. Next. One of the key features is that we are really excited about is the KeHMIS full order module. It allows users to prescribe ARVs, prescribe other drugs, view prescriptions, view active drug orders, and also view past drug orders. So as you can see from the image on the right, we have 4 tabs. We have the active orders, so you can view the orders that have been made. We have the standard regimen order. We also have other drug orders, and we also have past drug orders. So you can follow through for different plans and just see the past drugs that have been given to this client. Next. Okay. So previously the users could not do pill counts and could not also prescribe drugs. So the value add for providers is that you can easily track regimen changes. There's flexibility in calculating TX CAR. Also lays foundation for full interoperability with ABT. Also e-prescription and e-dispense. Support pill counts in KeHMIS. So as you can see, there is an active order that has been made for standard regimen. And for the lower section, you can see also if there are drugs that have been dispensed, you can see the drugs there. Next. So in addition, also we have a KeHMIS full laboratory order. So the full order module allows the providers to make lab requests, entry of lab results of order tests, also provides for panel of tests. Previously, providers could only enter lab results. So as you can see from the image, we still have the 4 tabs like the ARV dispensing. So we have active orders for the labs. So you can create different orders depending on the specimen, or rather the specimen that you've highlighted. So you can see the panel for blood, you can choose any test, and then you can choose specific tests for the different panels, and you can enter the lab results. So anyone in the different sections can just see all the active orders, and once the orders have been given, once you've given out the results, you can enter the lab results, and the active order section now will be cleared. Next. So another feature is the PMTCT MCH module. So the MCH modules have been enhanced. We have antenatal care data entry, maternity and delivery, postnatal care, pay, that's for HIV exposed infants, and EID forms, immunization forms, and HA outcomes. Some of these were there in the previous version, but they've been enhanced in tandem with the new PMTCT guidelines. So as you can see from the image on the right, we have the MCH forms that you can fill. And once the forms have been filled, they can just be seen at the bottom of that screen. So the other new feature for PMTCT is the mother-baby pairing. So we have relationships in KeHMIS that now includes mother-baby pairing. So as you can see, Chepsiror Dagili has 2 babies, that is varicella, the child at the bottom, and Kinyanjui. So you can add as many children that the index client has, and you can also be able to see the family and the partner tree. When you click on that image, you can be able to see the tree for that index, and the tree can go as far as the data that is available in the system. The value add for this is that it provides us setting the stage for K cohort analysis, also partner and index testing in MCH, and PMTCT outcome analysis. So we also have additional clinical forms that have been added to the system that were not there previously. We have DBV screening forms, alcohol and drug abuse screening forms, enhanced adherence screening forms, treatment preparation checklists. And the value add for this is that it provides access to clinical care information. It also improves holistic chronic care and sets stage for paperless EMR use. So previously we didn't have we didn't have these forms in the system. Now with these forms in the system, we can be able to capture a lot of information that we never used to capture previously. So this is really exciting to have the different clinical forms as per the request from the providers. Next. So we also have a feature that has been existing. This is not really new, the KeHMIS merge feature. So this feature enables us to merge possible duplicate patients, and the duplicates can be merged into one record. So this feature you can merge using different matches. So you can use the match criteria, you can click on the family name, given name, and then it will highlight the list of possible duplicates. So this feature allows you to just see all the information for the two possible duplicates. So you can merge and see the attributes. So the advantage of this is that if there are any encounters that have been done for the two and it's the same client, we can, when you merge, you will keep all the encounters, we won't lose any. We won't lose any encounters, so we'll keep all the. So the value add for this, it's an efficient way of finding and merging duplicates. It improves data quality. So this feature is also is now available in Acute Care, the new version, that's version 2.0. So what it takes to implement KeHMIS? So OpenMRS core platform has been updated to allow for full orders. Previously we were at core platform 1.9.10, but now with the full orders it's 1.12.0. Optimally it runs on 64-bit machine, 64-bit Ubuntu version 12 and above. The installers are available on GitHub for version 17.0.0. So this is so the new version will be 17.0.0. Thank you.
Okay. Thank you very much, Diana. I think some of the key highlights that I would just want to mention is that the PMTCT module is going to support the issues around accuracy of the TX card numbers, because that has been an issue that people have been requesting. By no means, this is by no means exhaustive. We have many other features on KeHMIS that it would be nice for you to be familiar with as part of the release notes that we have and some of the product features that we have. So the PMTCT module, I can see from the questions, is that people are asking if the PMTCT module is ready to use. Yes, the PMTCT module is ready to use. What you need to do is to be able to upgrade your EMR version to version 17.0 and have it implemented at the facility level for you to be able to access and use the services therein. So for now, I'll invite the next presenter who will take you through the Acute Care platform. You must note that the two platforms have similar functionalities. So Stephen Osewe will take us through Acute Care platform. Stephen has been developing Acute Care for a while now, and he's been very involved in Acute Care from the beginning. Steve, karibu sana.
Thank you. Hello everyone once more. So I'll take you through Acute Care, and the screen you can see right now. We have several services within Acute Care, Green Card being one of the most used service. The CCC patient card, MOH257, the blue card, and then we have the new menu, Universal Service Portal, and then PMSCM for commodity management. There's a screenshot at the top which denotes the new user experience that will be available in Acute Care 2.0. So we are still having a mix of the old and the new. So we are hoping within the next quarter we'll be able to harmonize the experience. So I'll take you straight to the new features in Acute Care 2.0. So one of the newest features is universal registration. With this, we are able to centralize registration. We've separated registration from the modules. This feature is also available in KeHMIS. So what is the value add for this? Patient-centered approach to EMR use. We allow providers to access all modules from one place, enable comprehensive care to the patient. So we've also integrated as a new search for patient. So without going to the patient homepage, you're able to see a summary of the services the patient is enrolled in, and also try to implement a newer wizard for patient registration that makes it easier and flexible for the people who are registering patients within the facility. Another new feature is the triage. Initially, for those who interact with the Acute Care, you realize that triage is tightly integrated within Green Card. So we've moved it out. So triage is an on-demand service within Acute Care 2.0. The value add for this is triage information shared to all service points. triage for HIV negative children like A and ANC and PNC is now possible. This sets the stage for Q feature in the upcoming release for Acute Care. Another big feature is the PMTCT module, which I believe all have been waiting for. So within Acute Care, we've integrated the PMTCT module that takes care of antenatal care, maternity and delivery, postnatal care, HIV-exposed infants. I believe previously guys used to have the custom-built modules, which they were using. Going forward, I think the new module in 2.0 will be able to better address PMTCT demands of our clients. Next. So another notable change that you'll realize in Acute Care 2.0, we've implemented a new service list where we are departing from the old way where you first access a service and then access a patient. Right now, you'll be able to access a patient and the system will tell you the services that the patient can access. So on your screen is an example of a patient. So this patient is not enrolled to CCC. This could be an HTS client or a ANC client. So you can see the numbers and you can see the summaries on your screen. Once you enroll this patient, in CCC, you'll be able to see the statistics changing. It will show you the number of the client and all the other details that are required. So we're hoping this will make it easier for clinicians and also make the service aggregated within one area, unlike before where you have to go to green card such a patient, go to blue card such a patient. So here, searching a patient, all the services become available within the homepage of that patient. Next. Looking at the PMTCT workflow, so these are the PMTCT workflow that we have. There's also a new UI, a new wizard. So we have the NC workflow, maternity workflow, PNC workflow, and HEY workflow. So these are tabbed and they are all interacting with each other. Like if you do an ANC, if the mother gives birth in the same facility and you fill the MOH, we have the pregnancy outcome being updated automatically to ANC. So we treat all the pregnancies as encounters which are updated via maternity service area. Thanks. So I think there's been an issue of assessment, and I think there's been a lot of requests, so we've responded to that need. So we've added depression screening within, for guys who've interacted with the online tool, you can see depression screening, alcohol and drug abuse, gender-based violence screening, enhanced adherence, barriers to adherence, case summary, follow-up education. The value add for this is we are supporting point of care use of EMR and also coding of comorbidities using comprehensive ICD-10 disease categorization. Next. Another feature that we have, I think many users of Acute Care will respond to this, is the patient match feature. So we used to have duplicate problems, which we've not been able to solve for a long time. With 2.0, this is one of the features that we're going to have out of the box. And the way we add it is, in trying to find duplicates, you can do comparison by names, where you can check first name, last name, middle name, or check first name only. You can do comparison by sex and enrollment date or date of birth. You can do comparison by program parameters, i.e. enrollment date, date of ART start date, and HIV diagnosis. So the value add for this is an efficient way of finding and merging duplicates and improves data quality and accuracy. On your screen right now is the details of 2 patients, which the system has suggested as possible duplicates. So you have the right and the left, so you can choose which data best identify the real data of the patient, and then you select the preferred patient. Just to send this out, the merge feature is reversible. Once done, you cannot go back because of the many encounters involved in merging the patient records. So I'm hoping most of the guys using Acute Care and have had this problem for quite a long time will be able to find a big use for this module. Next. Okay, so we've also extended Acute Care lab order. I think we have a lab service within Acute Care, which guys are used to, but we've extended lab order to be happening within PMTCT, just to avoid guys shifting from one module to the other. So if you're running on paperless, you can do a lab request in PMTCT, and the lab guys can be able to update all the orders and you see them on this newer version on PMTCT side. So the value add for this is improved usability. The provider can now place orders and view the lab results within a single click without getting out of the module. Next. What it takes to implement Acute Care. I think going forward with the new changes and enhancement in technology, we recommend a 64-bit machine, 64-bit Windows. If you're using Windows 7, for implementers who are using Windows 7, make sure you update it to Windows 7 Service Pack 3, but Windows 10 will be better. We've optimized the application for Google Chrome version 72, but we've optimized the application to work with Google Chrome. So any other browser will work, but Google Chrome works best. The installers will be accessed by GitHub, and the current version that is going to go out 22nd February will be Acute Care version 2.0. So we have a comprehensive upgrade guide for guys who are upgrading and for new installations that will be shared with you.
Okay. Thank you very much, Steve. I would like us to wrap up that session, but before we do, there are a couple of questions that have come in during the presentation that I would just want to respond to. So someone is asking about training. This will be handled later in this presentation. We have a team that's asking if the KeHMIS and Acute Care can be used on tablets. So specifically, they're asking about KeHMIS. So KeHMIS renders very well on tablets, and you can actually connect the tablet to your facility server if you have a wireless local area network. So you can be able to actually deploy it in a server with a bit of those inputs. Our team can be able to help you to be able to do that. In terms of the plans for upgrade, we'll be discussing this later in the presentation. Then one person is asking about registers, that MOH teams are usually interested in registers, especially in facilities that are using paperless implementation. We have worked to add registers to the system, and you'll be seeing that in the next session that we'll be going through. So I'll take the rest of the questions as we go along and respond to them in time. So I'll go to the next session, where we'll be talking about the data tools. So I'll take you to the next session, where we'll be talking about the new modules that are coming up so that we can be able to proceed. So we have new modules coming up. We'll have KeHMIS module, key populations module. This is under development with guidance from the key population teams. We are planning to do a prep module. The requirements are nearly completed so that the development for that module can then start. We are looking towards doing interoperability with the TIBU system. For those who have not interacted with the TIBU system, this is the system that is in use now for taking care of TB patients. So some of those patients are HIV infected, and we would want to make sure that there's integrated care with the HIV as well. So some of you may be familiar with PSMART, our smart card-based solution. We are making enhancements to make it cheaper and faster so that we can be able to provide you a solution that's optimized based on the lessons that we have learned. There are additional MOH registers that are continuously being added to the solution so that you have the whole suite of the MOH registers meant for HIV and PMTCT care. There is a countrywide issue with the unique persons identification. So we have been, we are planning to put in place an advanced search feature so that you can be able to search our national repository of person identifiers and be able to recognize duplicates in your system. One of the issues that is coming up is being efficient in deployment of the systems in the field. We are planning to work on an auto update feature so that we can reduce the need for people to move to each facility every time we have an upgrade. This feature is already available for DYP, Afia Mobile, and Muzima. We are hoping to put it in the EMRs as well. So I'll move to the next session, which will be taken again by Diana and Steve. So we'll be talking about the reporting tools. So some of the questions that you raised earlier will be answered in this session. So Steve, please take us through the next session.
All right. Thank you, Jacob. So I think we've looked at the two EMRs, we've looked at KeHMIS, we've looked at Acute Care. We are consuming data, how do we get it out? So here comes reporting tools. We have KeHMIS reports. We have data tools also in KeHMIS. And then we have Acute, which I think most guys are familiar with. For report generation, I think we've been generating registers. We've been generating the MOH and PEFA reports. You've experienced the Adhoc queries, both in KeHMIS data tools and also Acute tools, where you're able to select tables within the database and it generates a query for you. You're able to share queries across sites and also produce outputs. We have programmatic line list, standard line list, and custom line list. I believe these are tools you've already used. And then what's new? We have new reports and registers that have been added within the two tools. We have the treatment preparation registers, HTS lab register, referral and linkages register, ANC register, maternity register, PNC, and family testing register. Then all the reports are covering HTS, PMTCT, HIV, care and treatment. We have DYP MER 2.0, and then 2016 MOH 731 as new addition coming with the new versions. Below is an extract. On your screen is an extract for Acute tools. In this screen, you're able to move database tables within a database. You don't need to know how to write queries. Just dragging and dropping the tables and the columns. The Acute tools will automatically generate a query for you. You can have the query as a custom line list, save it within Acute Care, within Acute tools, and use it or share it across with another facility. Then again, the image below, you can have the SMS tooling within Acute tools. You're able to generate line list of appointments, schedule the appointment, configure SMSs, and be able to send reminders to your patients. All right. So the next one is a Adhoc query feature in KeHMIS data tools, which works the same way. You're able to pull tables from the data tool, select the columns that you want, generate a query automatically, and then you have your output. With that output, you are able to pivot the data, generate line lists, generate charts for maybe for your abstract and any other thing, or for disseminating to stakeholders. So I think another new feature that is coming up is AIR. AIR stands for Automated Indicators Reporting to the DHIS2. I think we've been piloting automatic sending data to DHIS2. So both Acute tools and KeHMIS data tool is capable of doing this. So we've tried with a small data set, and we are comfortably able to send data to DHIS2. So the value add for this is improve data quality by eliminating transcription errors, reduce reporting time. So I think we don't need any intervention. The EMR itself will be able to send the data directly to DHIS2.
Okay. So thank you, Steve, for this. I think for those of you who have not used KeHMIS before, please take your time to go through our training materials for an in-depth review of the KeHMIS data tools. Many of you are familiar with IQ tools. For a long time, it's been there, but data tools is something that was added around 2 years ago. So just make sure you familiarize. It will make your life so easy. The second thing I wanted to talk about is just the KeHMIS data tools, IQ tools, and also the data warehouse custom query tool. They basically operate in a similar manner. So when you learn one, the learning curve for the new ones are usually fairly easy. The feature that I would want to just make sure that you also get is that automated indicator reporting is a first for almost the whole of Africa and Kenya. With the bills of the EMRs that are going out, you'll be able to generate a message that can be uploaded to DHIS. We are looking at the SOPs and guideline related issues. So we are doing this as a pilot in the country in a few sites so that we can be able to inform the MOH guidelines that will be governing the automated indicator reporting to DHIS. So as we move along, this will become apparent and we'll be able to communicate some of those things. One final feature that I would want to point out is that one challenge that partners have been grappling with is changing numbers, especially the current on treatment numbers between months or between quarters. We have done a query that will be able to line list for you the number of people who have been dropped from a report between 2 months and any new people who have been added to the report, which means that if you reported 50 people in January and you are doing a report now in March or April that's showing 100 people, you will be able to get a line list from the EMR, from the IQ tools and the Kenya EMR data tools of the people who have either been added or removed from that list. In Kenya EMR, you'll also be able to do this right from the Kenya EMR platform itself. So this is one thing that we'll be sharing out together with these items, plus an SOP on how to run those queries. So for now, again, we'll change gear so that we can go to the mobile applications. So I'll introduce once again Diana to take us through mMuzima, and so that we can be able to go through the mobile tools. So Diana, please.
Thanks, Doc. So as we are aware, HTS we support through desktop application, that is Kenya EMR and Acute Care. And we also have mobile applications, that's Afya Mobile and mMuzima. So Afya Mobile interoperates with Acute Care, and mMuzima interoperates with Kenya EMR. So I'm just going to straight to the new features. One of the features that we're very excited about is the multiple facility configuration. So as you can see from the first image that's of Afya Mobile, you can be able to do multiple facility configurations. So with mMuzima system, the administrator can configure the server to host multiple facilities from which the different healthcare providers in various locations can also sync data to a common database. Another feature is linkage and referrals. We've decoupled this from registration. It allows updating linkage after pushing and pulling data from EMR. So as you can see in the images is that we now have linkage and referral register there in both mMuzima and Afya Mobile. We also have an allowance for repeat testing, the levels for repeat testing. So as you can see from Afya Mobile, we have testing and its indicated repeats. And for mMuzima, we have HTS retest form, and we also have referral and linkage forms for referral and linkages. This also allows for PSMAT, it's an enhanced functionality. So both applications can read and write from PSMAT cards. Another feature which we are very proud of is that we have a repeat encounter that allows repeat encounters after syncing. So after you've pushed data to the database, you can still pull that data and have repeat encounter for the same index patient. So you can see we have initial test and we have repeat test for this for Afya Mobile. And for mMuzima, we have HTS initial form, that's for the initial test, and HTS retest form for the repeat tests. Another feature that we had gotten many requests about is the kit history. The Afya Mobile maintains the last kit lot number and the expiry date. So in this case, it simplifies the capture of tests done using kits with the same lot. So initially, all the tests that you're doing, every test that you're doing, you had to put in the kit lot number and the expiry date. And we are aware that many batches will have the same. So in order to ease the work of the care provider, we simplified this to capture the tests so that it's pre-populated. Unless the batch changes, then you can change from Afya Mobile. It also allows for tracking tests done by kits of a particular lot. So you can also track these tests for that particular lot. Another new feature is the client summary showing. So initially we didn't have the summaries. So this is a new feature, HTS enrollment dates, for example, previous HIV tests, and referral and linkage information. So this is a new feature for Afya Mobile. So in the spirit of making the two applications have the same functionality, so these were added. So another new feature for Afya Mobile that existed previously for mMuzima is the ability to generate DNS Contact Tree. So for that particular client called John Doe, you can just see the contact tree, and the contact tree can go as far as the data that is available. So if you have as much data as available for John Doe, we can just see those trees generated. Also, like I mentioned, we also have HTS on the desktop applications. So the ones I've mentioned previously were the mobile applications. So we have EHTS on KeHMIS. So that's how the form looks like. It mimics the forms that are in the facility, and it allows you to fill those forms. We have the HTS initial form. We have retest for the ones that are positive in the first test. And also we have referral and linkage forms and the screening forms. So also on Acute Care, we have this EHTS module. So you can see the EHTS encounters, and you can have repeat tests for the different clients, depending on the results of the first test. And you can see the pretest and the initial. It also mimics what is in the registers, and the flow is the same. It follows what is in the registers. So I want to highlight the upcoming features. That's for both applications, Afya Mobile and Muzima. The next upcoming feature is user interface improvements. We aim to improve this user experience following the feedback that we get from the users. We want to come up with applications that really speak to what the user is wants, or rather it's friendly. So that is a feature that is upcoming. Another one is continuous improvements on the features of the mobile applications. So as we get feedback from our users, we keep on improving these applications and the system to suit that, what the users would really want. What it takes to implement these applications. So the platform, the mobile device and the tablet should be running on Android 5.0 and above. 7-inch tablet optimum. So the installers for both of these can be accessed on Google Play Store. So you search for Afya Mobile version 3.6 and Muzima version 2.20. So installation and upgrade procedures are available in the user guides that we'll be sharing after this. The links will be available so that you can interact with that. Thank you.
Thank you very much, Diana, for that comprehensive presentation. I think I'll again take just 1 or 2 minutes before we go to the next session to take you through some of the questions that have been asked. One question was that Afya Mobile kind of had pre-filled today's date while picking the date of birth. In the updated version, that field is blank. So providers have to actually look for a date of birth to pick and add in the application, so that there's no risk of persisting a date that's today's date. The other question has come up is there a plan to incorporate dual testing for PMTCT? So this is we are in contact with the HTS team and the PMTCT team to make sure that we get the correct requirements for this, and then have that incorporated after proper documentation. So this is something that is under discussion, and we'll be getting back to you with the final timelines for that. In terms of the DNS Contact Tree, for now, we are restricting the contact trees to the EMRs. So you will be able to see as part of the patient summaries whether someone is having partners. But now when you want the detailed contact tree, you'll be able to log into the EMR and be able to find the detailed contact trees for those people who have been tested. I'll take a break and move on to the next session. So this is one thing that's exciting, especially for the program teams who traditionally their work revolves around offices rather than health facilities. So please pay attention to Mwenda Gitonga as he takes us through the National Data Warehouse and the DYP tool that accompanies it. Mwenda Gitonga is very experienced in developing databases and managing data and analytics. So kindly take time, Mwenda. Karibu sana.
Thank you very much, Jacob. Good morning, everyone. As you've been told, my name is Mwenda Gitonga. I will take you through the data warehouse and the DYP tool sections. And then later on, we'll also move into the session for interoperability as well. Now, as we all know, all the data that resides in the EMR is collected on a periodic period, which is monthly. And we provided a tool called DYP, which actually allows you to collect data from the EMRs. The tool itself is cross-platform, and it has the ability to run on a Windows, Linux, and even a Mac OS environment. The tool is used to transmit data, and one of the key features that we have is that from the tool's design, it allows you to send data to multiple repositories, which means that even partners can set up their own repository to have a warehouse. Then the other repository that is also targeted, that is residing in the EMR, is a PSmart card registry, This allows us to back up patient card data where the PSMART tool is being used. And then finally, the tool also allows you to create a master patient index and also run unique identification and deduplication on the records that exist within your EMR. Next. So here's an example of a line list that has been produced from an EMR, and the tool is highlighting the number of duplicates that have actually been detected in that EMR. The tool uses a combination of both probabilistic matching and demographic matching. So the tool allows the people at the site to actually export this into a CSV, go back into the EMR and use the new merging features that are available to correct any duplicates that exist in their system. The tool also gives you a way to track what is being collected from your EMR. Once you do the upload, it actually suggests to you certain records that have issues, and you can actually click into those records and find what data quality issues that are appearing within your tool. So given this example here, you can see the first set of patients is about 4,024 records that have been loaded. That's out of 4,430. And the tool is indicating that 6 records will be potentially rejected because of some quality errors. So users can actually now click into that and find out what exactly is wrong with these 6 records, go back to the EMR and collect that. So it kind of supports data cleaning at the facility level. Then what does it take to have this tool to run? You need to be running a 64-bit platform. This is for Windows and especially so for the Ubuntu platform. The reason for this is because we use Docker, which is a containerization application that allows us then to install DYP on different platforms. So the Docker itself just runs on 64-bit architectures. So partners will be required to carry out upgrades of their EMR, of their operating systems on the servers that are running the EMR. The installers are available on GitHub, and we'll be talking about where you'll find these installers as we move on through the presentation. So other new features that are available in DYP. One, we want to be able to monitor EMR usage at the facility. This has been, in the past, we've seen data being uploaded, but the data itself is actually what you'd call stale. So we are going to be picking additional information using the tool. One of them is when was the last time the EMR was used, and also the report running dates. This should help us basically be in a position to gauge how well the EMR is being used at the facility, and whether people at the facility are beginning to adopt the EMR to run their reports. Then finally, we plan to extend the data sets there to include the PMTCT, which is also going out with the new EMRs. And this will now mean we have more data available in the data warehouse for analysis. So before we go to the interoperability layer, I think the DYP tool is a tool that will be very, very useful for you as a partner to be able to monitor how your EMRs are being used. So I think it's important that you take note of the presentation that has been made so that you can be able to do it. One thing that I would want to mention as a feature highlight is the ability to send data to your repository as a partner that we have built into this new DYP, so that if you want to take control of the data from all your facilities, you can be able to set up your repository and be able to direct, using the new DYP, the variables you want to go to your own database, so that now from there you can send to the national data warehouse. So later in the presentation, we'll be talking about data warehousing in detail. For now, I would want to move to the next part, which is basically the interoperability layer. But before we go there, again, I would want to request everyone, if you have not registered, please register so that we can be able to provide you with more information, and we can also give you an opportunity to provide feedback on how this webinar has gone to help us improve the next ones. So, Mwenda Ginonga, please continue. So the next part of this is actually we're going to talk about the interoperability layer. And the first thing I'm going to give you is just basically the interoperability context at the facility. what we have is we have a suite of applications that run as individual silos within the facility. So in the pharmacy, you'll encounter the ADT tool. In the clinical area, you'll find the EMRs. And you'll also find that we also need to exchange data with the DHIS, which is above the facility. So what the interoperability layer does is that it exposes a couple of standards that we can use to carry out data exchange between all these systems within the facility. That is, for example, if a patient gets registered, whether it's in KeHMIS or Acute Care, ADT gets notified on that registration. Where you have tools like T4A and MLab, which are returning viral loads, which returns viral loads from the national level, the data can actually flow from the national level back into the EMR and into the patient file. So what we've done is that the interoperability layer now, it frees us from having to have multiple connections from one system to another, but actually everything is routed through the layer. So how we achieve this, one is by implementing messages that allow us to do registration. It means that EMRs can be the registration point within the facility, and that registration can be shared across with a facility that is implementing ADT or Ushauri, for example. Then we also have messages for pharmacy, prescription, and dispense. So if the facility has both an EMR and the ADT dispensing tool, then the interoperability layer can come in between to route messages of prescriptions to the ADT tool, and once the prescription is served and dispensed, the response can come back into the patient's file through the interoperability layer. It also allows us to exchange information, especially triage information like height and weight, which is critical for dispense. So the messages to do that exchange are also available in the layer. Then the layer again is used to bring back viral load data into the facility. So as opposed to the current method where the results are available and they need to be printed and put into the patient's file, now the SMSs that are sent from the MLab application to the facility can be intercepted and actually routed into the patient's record within the EMR. Then finally, both EMRs have been upgraded such that they can communicate to the DHIS, and actually they communicate through the interoperability layer to achieve this. And that is the AIR feature that both my colleagues talked about earlier when they were taking you through the EMRs. So what does it take to actually get this to work within a facility? One is that now all systems must be implementing the same standard for CCC numbers, which is what we use, is the number that we use for identifying patients within a facility. So we expect that number to be in 10-digit format. So for this to work, we'll probably need to carry out a cleanup at the facility depending on how the number has been implemented before that. Then two, you must be upgrade to the current versions of all those softwares that need to communicate with the interoperability layer. So KeHMIS, you will get the new release that is coming out. That's 17, sorry. And Acute Care, which is 1.007 and above. Then ADT are on 3.3 and are upgrading to 3.4, which will also be a requirement for you to be able to exchange data. Then finally, MLab, T4A, Ushauri, you'll also need to upgrade those to the version that is compliant with the IL. Then finally, there needs to be a stable and reliable infrastructure at your facility. So for example, for you to carry out facility level data exchange, you must have a network, a local area network that is stable within the facilities. And then for you to exchange data upwards with the DHIS, for example, you'll need to have internet connectivity to send data above the facility. Then finally, to receive the VLs, we're using an SMS connection. So there needs to be a modem within the facility that actually is able to receive these SMSs for viral loads. Finally, when all is said and done, the data that has been integrated both from the EMR is uploaded using the DYP tool to the warehouse. So at the top over there, you have the link to the warehouse that is hosted here at NASCOP. And just to give you a quick summary of what the warehouse is all about, it's a repository where all the EMRs are able to send specific data sets that we collect for further analysis. Currently, it has about 1.8 million records of patients ever started on ART. That includes all the people, historical records all the way back from 2004. And currently, it's hosting about 388,000 active patient records. This number keeps on increasing as more EMRs are rolled out and more people upload data. Then the tool, it also provides an analytics and visualization platform where now you can actually have interactive dashboards that allow you to query some of the data that is coming out of these EMRs, supporting both case-based reporting and cohort analysis. It also has a feature for GIS, which is also work in progress, and we expect to see a lot of improvement around geospatial data. Then finally, it allows you to have a custom query tool, which allows you to formulate your own questions and provide queries that can be run against the data that is coming from the EMRs. How do you gain access? So if you go to the link that was shared up there, you'll be encountered with a portal. And one of the things is that you will be allowed to get in as a guest without login, but what you'll view is actually limited. But to get an account, you'll also need to basically fill out a form that tells us who you are, and the request is forwarded to your organization's data steward. So that means that every organization that needs access will need to nominate a steward through NASCOP, and the steward then will get the rights to be able to add users from his organizations into the resource. So if you go to the link that we just shared, for example, you will be encountered with a landing page. So the landing page just gives you quick fire statistics that try to take a snapshot of the second and the third 90 cascades. With that, you don't need a login to actually see this kind of information. And also, if you expand the button on the left, which is highlighted in green, you'll be able to see other reports that are also accessible to the public. Like, for example, last year's 2016 cohort report is also available there. Now, if you get access to the login, the new features that are available within the warehouse is that, one, the fact that we removed the requirements to actually have a login and allow you to see certain public dashboards. So, for example, the cohort analysis reports, the EMR baseline dashboards, which tell you when we deployed EMRs for the first time, what state were they in, and how are they deployed. That information is available. But for you to access other programmatic dashboards like live active on ART, the live cohorts, ARB optimization dashboards, then you'll require to have a login and create an account for yourself. Then we also have an addition of data quality dashboards. We have an addition of data quality dashboards, which allow people like program implementers to look at what are the reporting rates from the sites where they support, and also report on completeness and accuracy and data accuracy in the warehouse. So the warehouse, in terms of design, we've divided it into three main sections. So you have a published section. Again, this is the one that has interactive dashboards that do not require login. And then you also have the live section, which has other interactive dashboards but require you to log in. Then finally, one of the features that we're really excited about is the Adhoc section, which allows you to generate data on demand. I'll talk about that just a little bit more. When you have the requisite rights and an account, you can select the custom query under the Adhoc section, and you'll be given access to a query builder and a query results viewer, and also a web pivot, which allows you to basically design your own query, extract the data, pivot it around the way you'd want, and also download it. So this is an example of a simple query that has just been ran against the warehouse. It just gives the people who started a line list of people who've started on ART, and I can actually export this into the different formats there, either as an HTML, CSV, an Excel, or even an image or a PDF document. Then I can take this out. If I take it as a CSV, I can actually put this in a different analysis package or software like SPSS source data and actually carry out additional analysis on that. So finally, I talked about the quality dashboards. So the quality dashboards basically allow us to monitor the quality of the data that is coming in to the warehouse at the very high level, and we give you back the results. So you can see quality by county, and you can drill down all the way to a facility, or even an SDP or a partner. You can actually view the quality of data that is within the sites that you support. Then finally, all this information and the training manuals and data dictionaries are available on the resources page. And the resources page also has additional material that basically has, we plan to share information like, bulletins and photographs from different workshops that we may have had where we carry out training. And then in addition to that, all the training material that covers the tools that you've just been introduced to, or the ones that we are releasing, are also available here. So you can, with one link to the warehouse, you can go to the resources and download training videos, training manuals for either the EMRs or the applications that we've shared here from the resources page. This does not require you to have a login, so it's public information we can easily access. And I think with that, I will give it back to Jacob.
Yes, so thank you very much. That's a lot of information. Thank you very much, Brenda. I think I just want to make some few statements to help. One is that for you to get data in the National Data Warehouse, you have to basically use the EMR and upload that data. So the DYP tool is the tool that will help you to review that data and upload it to the National Data Warehouse. So I think that's very, very important for you to note. The second thing, Mwenda has taken you through the reporting page, the data quality page. One thing that is a new feature right now in the data warehouse is you are able to monitor reporting rates in real time. So you can be able to know when data reaches the National Data Warehouse when you upload it. And then secondly, when you log into the National Data Warehouse, especially for the program teams, the county teams, and also the national teams, you can be able to view reporting rates, so that if you have 50 facilities and only 25 have reported, your reporting rates will be at 50%. Finally, what I would also want to add is that we recommend that data is uploaded to the National Data Warehouse monthly. So please just take note of that. So without taking any more time, I'll ask our next presenter, that is Patrick. He'll take you through the service desk. Patrick has been experienced a lot in EMR implementation at the site level, but he's also now coordinating our service desk, and he'll be able to guide you on how to seek for help now that we are rolling new applications and new modules, so that you can be able to use the EMRs without interruption. Patrick, karibu sana.
Good afternoon. My name is Patrick Shuk. I'll take you through the service desk. Please, I will start by asking you to note the number on your screen. That's our service desk number. It's a toll-free number. You can call anytime between 8 and 5, and we'll be able to respond to your query, your issue, or whatever of all the tools that we've taken you through today. If you have any question, please call this number to ask any question. The service desk has several ways in which you can access. We are trying to provide structured support to our users and stakeholders. So one of them is a toll number, the free toll-free number that I've listed. Secondly is that you can be able to create your own ticket. If you go to the URL at the bottom of your screen, you can be able to create your own ticket and document all. Please note, when you're creating your ticket, you can select the system you're using, indicate for us the version that you're running in your facility. What were you doing when the issue happened? What is the environment? What are your numbers? This will enable us to be able to respond to your ticket. And once we have any interaction with your ticket, like we have assigned it to someone or we have updated it, you'll be able to receive a notification when you create your own ticket. There is also a Spicework Help Desk Google app that you can download in your Android phone, and you can be able to use it to track all your tickets. On the left of your screen, you can see the several methods. If you scan that QRC code, you'll be able to get the details about the help desk. And when you install the help desk app, next. So I'll talk about the help desk Android app. So for you, if you go to Google Play, you can find an app called Spiceworks Help Desk. You download it, but for you now to access our help desk, you need to go to the link we provided in the previous screen, create an account, then use that account to log into the app. Then from there, you'll be able to create tickets. Please provide as much details as possible. The screens on your right show examples of someone creating a ticket, and you can be able to track all your tickets. You can see what has been done, what updates have been done to your tickets. When your ticket is closed, you'll be able to receive notification. We are really encouraging and requesting that you use the Android app because it will be able to allow you to monitor your tickets from anywhere. Now, alternatively, you can create the tickets on the web by visiting the URL we have there. This is a sample screenshot of the ticket. Please provide us your contact, a summary, a description of the issue you're having. You can actually choose to assign that ticket to someone, what is the due date, the priority you are giving it, category, whether it's at your mobile, KeHMIS, whichever it is, the tool that you had an issue with, and the version that you're using, your contact, so that we can reach both your phone number and email. We can reach you for clarification just in case we need any more details. Please provide, what I would comment is that please provide us with as much details as possible so that one, we are able to understand your issue, and two, we are able to resolve it in time. Future plans for the service desk is that we are planning to build a knowledge base out of the frequently asked questions that we are receiving. This knowledge base will be accessible to all users. It will address mostly all the issues that are documented about any of our systems. Number two is that we want to develop a tiered service support that will incorporate service delivery partners as part of the support. So we are starting by mapping all the facilities to the service delivery partners. This will enable us to know who are supporting which facilities. Secondly is that we will build capacity for the stakeholders to provide first-line support. So in the next slides, I'll be talking about how we are planning to do the capacity building. Secondly, after we've done the capacity building, when we receive tickets from facilities that are mapped to an SDP, we'll channel them to those tickets to that particular SDP for first-line support. This will allow SDPs to know what is happening in the facilities that they are supporting, know what kind of tickets that we are receiving from that, and plan for appropriate maybe training or support. Next is that we are going to monitor quality, uptake, and performance of service desk. We'll be sharing tickets received from certain facilities to the SDPs to be able to know what is it that we are receiving from their facilities. So I'll continue with the training approaches and materials that we plan to do. Now that we have all these new release products, we have come up with a cascaded training model that will enable us to reach all our users with the new releases. So first we have iTech and Palladium, who have developed content that is available on the resources page in Data Warehouse. So this will target TOTs, mainly EMR users and data use. This will be an EMR user and data use training, and also system admin and help desk training. These TOTs can now cascade that training to county MOH and SDP TOTs. So they'll conduct facility-based training. They can cluster facilities together and train them. Basically, they will undertake, this will be an end user training, and they can also do the facility-based system admin and help desk training. Finally, that team that will be trained at that level will cascade that training to the champions, the HIS tech champions, and end users. So these guys will do the UAT at the training at the facility to now be able to train the healthcare workers and anybody else who's at the facility. So what we have done so far is that we have completed training for KeHMIS system admin training that was hosted and SDP sent to their representative. We have done ESTS trainings. So what you're planned to do in the coming days is Acute Care admin training. We'll communicate to you the schedule, and you can send your selected participants. Please identify who will be actually doing that work as participants for this training. We've also planned a TOT training for PMTCT. We'll be also sending out the schedule for this training. So to access the materials, as my colleague Manda mentioned, these materials are hosted at the data warehouse resources page. And if you go to that page, you can be able to download content as you need. We have both PowerPoints, PDF, and videos for you to reference anything that you might need. So how are we going to do our training? Like I said, we are going to do technical support teams. These will target the system admins. Then we'll have the end user trainings that will be cascaded by the system admins that are being trained. Data use that will target data and health records team and database users. So these are anybody who is using data generated from the EMR and the EHDS apps. They will be part of this training. And finally, we'll have a training for program decision makers, which will basically show them how to use the data, mainly addressing policy briefs, bulletins, and newsletters that will be developed. So the strategy and approach is to shift to online training. So we are planning to host our training materials and video jobs online on YouTube so that you can be able to go there and access them. Then we'll also host webinars like this one to conduct training on various components and systems that we have, both the webinars and echo sessions. So we'll have something like this for training. We also plan to have structured support through service desk. Via, like I said, the knowledge base, you can be able to go to the service desk and access to our knowledge base, and even self-train on some of these things. We'll also be broadcasting messages on new features via the emails we are collecting. We have given you a registration form. Please register so that you can have your emails we will be able to send to you once you have addressed some of these issues. Finally, we'll be conducting face-to-face trainings on need basis that will be able to address the training needs. Thank you very much.
Yeah, so thank you very much, Patrick, for that nice presentation. I think I want to just emphasize certain things that Patrick mentioned in his presentation. First of all, is the shift towards online training approaches. This is a very deliberate way for making sure that we also are responsive to some of the training needs and to provide partners with control of who they invite for trainings and when. The second thing is the tiered approach or the cascaded model of training. So Kenya HMIS is taking that tiered approach for both training and also for technical support. So for training, we are going to be investing a lot of time to understand your organizational capacity to do training in terms of your TOTs, in terms of the number of people you have for training, so that you can be able to target these people with trainings, and in turn, they will cascade this training to the staff that work in the facilities that you support. So this is important because you need to try to put in place measures to have enough human capacity, enough people, and also so that you can build their capacity to cascade these trainings. For technical support, we have, again, two approaches that we are using. From the presentation, you may have picked them. The first one is through a structured support through the service desk. So a lot of the traffic, we are really hoping that you can check this up and address and target most of the traffic in terms of requests for support through the help desk, so that the help desk can be able to respond to your issues in real time. The numbers we have provided is toll-free, so it has no cost to users, so they can call at any time when they need help. But we also want to work together with your technical support teams so that they can be part of our help desk and be a bit more responsive and aware about issues that are coming from the facilities. We have an emergency support team that will be on standby in case you are stuck completely. They can be able to come and help to unlock some of the issues that we may end up being stuck with. So I think that's basically a summary of the approaches. So the reason we have posted all the training materials online is so that when you as a partner or a county, you want to conduct your own trainings, you don't have to totally be dependent on Kenya HMIS. You can go and take the training materials and be able to support the trainings. And finally, it's just on the video job aids. These are fairly short videos that you can take and share even on WhatsApp, so that in case a user needs to refer to a video job based on how to undertake a specific task they require for service delivery or reporting, they can be able to go and do that without being dependent on anyone. So the face-to-face trainings will be really reduced to be on a need-by basis. So we'll be discussing those as we move forward. I think we'll have a brief session on Q&A, but as I had indicated earlier, we would like as many questions as possible to come through the app. Our admin will be looking out for anyone who has raised their hands and be able to take the prerogative to decide who will be responded to. So please feel free to raise your hand to ask so that some of your questions can be responded to. Yeah, so for those of you who are on video, if you have a question, please just wave so that we can be able to see who you are. Maloba, please speak, we can hear you.
I hope you can hear me.
Yes, we can.
So with the new change of 17.0.0, did you change the way regiments are saved in the DB?
That one is KeHMIS, right?
Correct, yes.
Okay, we can take a second question as we wait, as we prepare to answer that. We answer a batch of like 2 or 3. Okay, Adjuang, you can ask a question. We can hear you.
I'm just going to post my question. It's relayed from my partner. I'm going to post it on the chat line.
Didn't get the question.
You're not clear.
Adjuang, you're not clear. Please, could you please repeat your question?
I'm going to post the question on the chat line, please.
Okay.
Okay, thank you.
So maybe I can respond to the question around regiments.
Yes.
Can you hear me?
Yes, we can.
Okay, so the workflow has changed, but it's mostly on the interface. The database has not changed much, so there is nothing to worry about with regard to data extraction. That is, if anyone had been using the previous table setup.
Okay, does that answer your question, Maloba?
No, not really. When I pull up patient level data, it gets me the regiments with full colons. So it gets the whole lot of it there when I only just need maybe just the current regimen and the start regimen. So the rest can just be dropped off. And I just have just the two, the start and the end.
Maloba, maybe we should go, we should take you through how to extract that data from the database. Because so we have a database which is specifically meant for that purpose. Maybe you are using the internal one, which is meant for internal reporting within the EMR. So we just need to take you through that.
Okay, that would be very great.
Okay.
Yes, any other question that you can respond to? Yes, I'm seeing a common question that's coming in the chat section about the additional forms, adolescent checklist, KJ. So I'll just request my colleague Kamau Mataga to just respond to that question right now.
So we have PHQ2 and PHQ9 already in the EMR. We have alcohol and depression screening form. I mean, that's the alcohol and depression screening form, the PHQ. The depression screening form is PHQ2 and PHQ9. We have that. We have the alcohol and drug abuse forms as well. That is the CRAF and KJ. For the adolescent checklist, if you look at the questions you ask for the adolescent checklist, they're actually part of the clinical encounter. You know, things like LMP are using FP and things like those. So as you use the encounter form, we are collecting what is required for the adolescent checklist as well. We've added a number of adherence forms, so that the enhanced adherence form is there. Barriers to adherence are also there. So we've added all those.
Yes, so I just want to again respond to one of the questions. The OTZ enrollment, we still don't have those in the EMR, and I think we take note of that question, and I think we'll discuss what to do about some of those questions. So someone is asking, can we document an initial test for clients who declines a second test when the first test is positive? I think this is an interesting question from Kennedy Mutua. I don't know if maybe, I don't know if someone can respond to that one. It's interesting. I don't seem to understand what the request here is. Probably what we'll do is maybe you can just send follow-up messages to clarify what your request is. Then we'll be able to come back to that question or respond to it as part of the chat questions that we'll be responding to. A question is coming about upgrades to the EMRs to cater for MFL codes from other countries, e.g. Uganda and Tanzania. Again, that one is a question we'll respond to during as part of the chat questions that we'll be showing you. A request about what of mother-baby pair in IQ care and differentiated care. So yeah, mother-baby pairing is now possible in both EMRs because of the PMTCT module. So please just go back to the release notes and also interact with the online versions of the systems that we had shared as part of the email invite for this. One of the things that may not have come out during the interoperability layer discussion is that as now that we are rolling out PMTCT, we'll also be putting in place ways to pull the EID results from the viral load database so that this completes the support for the HIV-exposed infant, early infant diagnosis activities. Okay.
So on the person asking about how to save the initial tests when the client declines a repeat test. So for now, the EHTS apps requires you to do the both tests before you save. So that's an issue we are going to look into and find a way forward.
Yes, and I think this is kind of a procedure issue because I think for you to give someone a final result, you need to have a second test if someone turns positive on the first test. So I think it would be nice for us to hand this over to NASCOP later so that the HTS team can guide on the workflow for that so that we move forward maintaining our adherence to the guidelines. So I think for now we can move on. We can revisit any questions if we have any more time at the end of the presentation. So for now we can go back to the the presentation. So at this point, I'll introduce Pascal Mwele, who is our Chief of Party for the Palladium Kenya HMIS project, so that he'll take us through the next session and also bring in the National Ministry of Health team and CDC team so that they can be able to help us through the next session of this presentation. So Pascal, karibu sana.
Thank you very much, Dr. Jacob, and thank you all for attending today's session. We decided to take a different approach to how we do our release management. And so any feedback that you provide us on the link that we gave you, we'll get your contacts. We'd like to get your feedback on how effective we are in this first trial. And then we hope to keep this as an ongoing practice, but also improve on it. So thank you very much for attending. I'd like now to invite Dr. Kimanga from CDC to give his closing remarks and also reflections before inviting NASCOP to close the session for us, and also for them to tie up and give us what the next steps are. So I'll invite Dr. Kimanga also to talk to us about the different roles that we are going to play, that we need to play to ensure that EMRs have the right adoption and use at all levels. Dr. Kimanga? Davis? Dr. Kimanga, if you can hear us, type something on the chat. Okay, so probably in the meantime, as we wait for him to come back online, I'll hand over to NASCOP, Faith, to have some reflections and also to guide us on how we need to move from this.
Dr. Kimanga, are you online? Okay, so I think for us is first of all to appreciate everyone who's participated in this session. And I want to echo the words of Pascal that this is our first trial and hopefully we're going to have more of this. So we really welcome all your inputs on areas that you think we need to improve to make it better. I know a lot has been said and it's a lot of knowledge. I know people are saying the session is very good, but the time that has been allocated is very short. But as said by many of the presenters, the materials are available for anyone who can be able to go through them. But for those who don't like reading, I believe there are lots of the videos that you can listen to, just like the way we listen to other videos, and I believe the message will be passed. You've also been given a contact line that is open and is toll-free for reach in case you have any queries or any problems that you'd like resolved. So do not shy off from doing that. Just reach on to us, and hopefully we are going to make it better and to pass more. My last two things is that one, this is a really great move. We all believe it's been a walk from those who were with us previously when EMRs came into being and where we are today. If you look back and look at them now, you can see there's a lot of involvement. So it's my hope that this will continue being, and hopefully we are going to be able to accommodate all the needs to make sure that we give our patients care and management as needed, and also be able to derive the information that we need for strategic planning and decision making. So basically, I really want to call upon our colleagues at the counties, that's the county aides and STI coordinators, that's the CASCO, please. This is your role to ensure that moving forward, you ensure that all the EMRs that are in your counties are up and running. And in our next county review meetings, we shall be looking at how many EMRs are in your county and how many are functional and how many are not functional, and probably how many are not working. So I call upon the CASCOs to sit together with the implementing partners on the ground, make a report of the status of your EMRs and what you really need to make them move forward. So before we even go to ensuring that we have 80% of our clients on EMR, we shall first optimize whatever is existing to make sure that we are able to deliver probably the 40 or 50% that is already on EMR to the level that it should be. So the call as NASCOP is to make sure that you sit together with your implementing partners, figure out which EMRs are on the ground and how good are they. And probably what the team did not say is that you're not just looking at Kenya EMR and Acute Care. I think it's important to note that data that is received in the repository, that's the data warehouse, is not just from the two systems. We have data from the AMPAD sites, that's AMRS, and we also have data from the FACES sites and the ADAP sites. So we are looking at working together with all possible EMRs as long as it meets the criteria or standards that are being provided by the team to make sure that data is put into the data warehouse. So we really look forward to that. So as you prepare for your county review meetings, which I know will be happening in a very short while, kindly just make EMR one of your topics or one of the things that you're going to look at to ensure that we optimize its use. And of course, as NASCOP and together with our USG partners, we are looking at making sure that we have 80% of all our clients on EMR. So we will have a rollout plan, or we have a strategy that is being put together by the USG team, the NASCOP team, and the larger Ministry of Health team to make sure that we adhere to all guidelines that come along together with EMR implementation. So hopefully before probably mid of this year, we will have a lot of new facilities having EMRs, and I believe even the partners on the ground know this, and some have already gone ahead to make sure that it happens. So my call to my colleagues is that please support them in ensuring that it works and optimally does that. So I believe the session has been very good. I don't know whether Dr. Kimanga has come back on board. Dr. Kimanga? Okay. Looks like he... Dr. Kimanga, can you hear me?
Now I can, sorry.
Oh, thank God you're back. What happened? Anyway.
I was having problems with technology, so I had to figure out how to press start it.
We are happy you're back, and we really we were really eager to listen to your parting shot before we end the session. So, Karibu, and probably you can go ahead and give your remarks.
Okay, thanks, Faith. Really appreciate, and really to begin it off, I wanted to appreciate NASCOP for actually allowing us to host this very important talk through the Zoom platform. It was my very first time to interact with this. It's very powerful. I noted that there are more than 100 participants in this, so it's very exciting that we can reach as many people within this approach. And I really secondly want to thank the Palladium team. I mean, this is quite innovative. It's a very good way of keeping in touch with your clients out there. And from the many questions that were being asked and everything else, it's very clear that people are very engaged and they are very excited about the many new features that you've added within the system. So a big congratulations to you all. Very importantly, again, we wouldn't do much on the platforms if we didn't have clients. So again, to appreciate the county teams, the facility teams, and the service delivery partners who are our primary clients in the use and the implementation of electronic medical records. So from our end, we see EMRs as platforms that are going to be used to improve clinical care, but also improve reporting. And with the many exciting features that have been added here, it's a way to show that we are quite responsive to your needs. We may not have met 100% of your needs, but I think we are making progress towards ensuring that the systems are really what you want them to be and really what they ought to be for all of us. So I really look forward to this continued partnership that would help us to get the best out of the digital health solutions that we are developing. And it's my sincere hope that we will continue collaborating to make this work for all of us. Something to note, and it's very important for all of us to know this, is that one, the EMRs or the systems, the digital solutions that are being developed are really from a public health approach, and they are meant to cater for cross-cutting needs. So wherever we are developing is something that MOH and PEPFAR have kind of agreed that these are the features, these are the functionalities that are needed. I know when we go partner by partner, each partner may want additional features, but it's really a challenge for us to customize the systems for a particular partner. But wherever has come out as guidance from MOH and guidance from PEPFAR, and if it's a cross-cutting needs across partners, then those are features that can potentially be added within the system. So let's not really come up with very partner-specific things, because the partner-specific things may not be included in a national health information system. So that's important to note. The second thing is that over many years, we had initially, if you look at the initial deployment of digital solutions, the EMR partner or the HIS partner were actually responsible for virtually everything. But over time, we've realized that that's not something that we can sustain, because there are more than 1,000 sites that have electronic solutions. And definitely, there's only one partner at the national level who is supporting all this. For this reason, we are increasingly really want to develop very good partnership where the service delivery partner would take over day-to-day management of the electronic systems, and let Palladium as the HIS partner focus on developing a robust solution, so that at the end of it all, the day-to-day use of the system, deployment, ongoing support, to the greatest extent possible, would want this to be handled by the service delivery partner, who is already at the site and visits the site more often. And then we want to pledge that from USD perspective, that we will do our best to ensure that the solutions are being developed by the HIS partner in a way that meets your needs. I think if we have very clear role separation, this is going to help us to get the best out of this collaboration. So moving away from having Palladium being called to fix a mouse, I think is an area that we want to see how best the first kind of response can come from the people who are already on the ground, or the people who already have more boots on the ground. Another very important thing is that when we did the last national level data quality assessment, it was very clear that sites that had electronic systems did much better in terms of data quality, and they played a key role in ensuring that Kenya did not have to apply a correction factor. As a result of that, the common understanding of vision by both MOH and PEPFAR is really to ensure that majority of our sites, which are high volume, are actually using electronic systems. And our goal is to really ensure that when that happens, we'll be able to have a very rich data set that, as was presented earlier on, is going to be made available to the partner supporting the site, but also at the national level to be able to monitor how the program is moving. Some of you are actually being supported by PEPFAR, and you know that every now and then indicators keep on changing. And like even now, there is something that we noted in the last report, that number of clients on treatment has reduced in a number of sites. And part of this is really the ability of the partner to investigate. One new feature that has been added in the reporting is you to be able to run a line list of who was counted before and has not been counted in the latest report. And then also who is counted in the latest report and was not counted before, so that you can drill down and go find out why are you losing clients or why are you gaining clients. Gaining is not bad, but losing clients is really something that is taking us back in the past to epidemic control. So in a nutshell, I want to pledge that from the USG perspective, we are very keen to, from an SI team and the clinical team, we are very keen to ensure that we want to embrace electronic medical record system, digital solutions that are communicating to each other And Palladium is committed to ensure that they meet your needs to the best of their ability. We call upon you once we've done our bit at this level, then for you to really roll this out on the ground to ensure that it's being used continually and it's contributing to the control of the HIV epidemic alongside other existing diseases. So that's all for me, and I really want to appreciate you all for creating the time, and we hope we'll keep on interacting as we move on.
Okay, thank you very much, Dr. Kimanga, for the comments, compliments, and also the insights that you have shared with the entire of the team. And I think I want to appreciate everyone for the good participation, having 100 and something, above 100 participants active for the entire 2 hours. I think it's quite commendable. So on behalf of the NASCOP leadership, Dr. Keegan, and the SI team lead, Dr. Joyce, we really want to appreciate all of you for participation, and we look forward to ensuring that we have more of these sessions. Your remarks are very much welcome. Do not shy off again from sharing, because that is what is going to make us better moving forward. So thank you very much, team, and we have a comment from my colleagues who've been presenting with us. We really want to say thank you and wish you well.
Yeah, thank you very much, Faith. And this is Pascal, the Chief of Party working with the Palladium team. And I just want to appreciate you all. I just noticed that we have a retention rate of over 85%. For our first webinar, that is really good. We hope that we'll keep it to 99.99%. So thank you all very much for attending. We will, as we've shared in the chat, we will be sharing the presentations. So please make sure that you register and that we have your contacts, because we'll be sharing the presentation and also a video of this. And finally, we've mentioned that there's a resources page on the data warehouse platform. Please take some time and log in and find out what are these resources. Are they comprehensive enough to empower you to move on to ensuring that you support the facilities in deploying the EMRs at the facilities? What else do we need to add? So the engagement from you is really critical to ensuring that we succeed in this. Otherwise, thank you very much, Faith, for hosting us. Thank you very much for your leadership, and we look forward to the continued partnership.
All right, thank you, bye.
Bye. Thank you.